combination with either BMI less than 20 or sarcopenia, which is a generalized loss of skeletal muscle mass and strength. Alrighty, so looking at my first research article that I chose, it's titled "A Cross-Sectional Study That Examines the Prevalence of Cachexia and Areas of Unmet Need in Patients with Cancer." So the primary purpose of this study was to assess the prevalence of cachexia in an unselected cancer population, while also assessing the patient's perceived need of attention to their condition. And then the study's goals were to increase awareness of cachexia and the patient's related needs to the condition. And then they also aimed to establish the concept that by understanding prevalence, we can better assess for palliative care. All right, and then so participants in this study, they had to be greater than 18 years old with a cancer diagnosis, couldn't have surgery the preceding 24 hours. They had to read and write it Norwegian just because that's where the study took place. And then they had to have sufficient cognitive function to complete the assessments to get the data. And then any participants that had missing data on BMI or weight loss, or patients who had surgery in the preceding 24 hours were then excluded from the study. Alrighty, so some statistical considerations. The prevalence of cachexia was estimated in total by gender, age, cancer stage, cancer type, oncologic treatment, and treatment intent. And then the patient perceived need of clinical attention to weight loss and nutrition was then estimated and stratified by in and out patients, and then whether they had cachexia or no cachexia. And then due to the difference in length of recruiting and the resulting sample size, as well as the clinical differences between the in and out patients, they reported these results separately. And then looking at the study design in patients, this was a cross-sectional study among in and out patients, and they did this at 3 different sites. And like I said, this was in Norwegian area. And then for inpatients, they were conducted at departments of surgery, medicine, and medical oncology, and these were on predefined days in September of 2013. And then the outpatients were a little bit different. They were recruited from the Department of Medical and Radiation Oncology at the University Hospital. This was in January of 2014. So a little bit of a gap there, but. So looking at the results, for inpatients compared to outpatients, the inpatients reported a greater 6-month weight loss, which was a 6.3 kilograms. And then symptoms that they were most prevalent in these patients were appetite loss, early satiety, altered taste, which is kind of where I mentioned with my aunt, that was one of her biggest symptoms. So these were most prevalent nutritional impact symptoms experienced in these inpatients. And then this ultimately causes 62% to report that dietary intake had been less than usual. And then overall, 51% had cachexia, or a prevalence of cachexia, which is a big number. And then looking at outpatients, they had a smaller reported weight loss, which was over the 6-month period, which is a 1.7 kilograms. And then the most prevalent nutritional impact symptoms for these patients were altered taste, early satiety, and dry mouth. And then with that, 24% reported that their dietary intake had been less than usual 2 weeks prior. And then overall, 22% of all patients experienced cachexia prevalence. So lower number than inpatients, which I guess is a good outcome. Alrighty, so then this slide is demonstrating the connection between cachexia prevalence and cancer type. And then this association was confirmed to show the strongest association out of all the factors that I listed previously. So for inpatients, you can see that cachexia is most prevalent in the lung cancer, the gastrointestinal cancer, and least prevalent in the hematologic cancer. And then you can see the breast cancer, they did not have any data on that, but they did for the outpatients, which you'll see, which I thought was a little odd, but. Alrighty, and then looking at outpatients, similar to inpatients, for cancer type, most prevalent in lung cancer and gastrointestinal cancer, and then lowest in the hematologic. And then looking at the breast, you can see that it's also lowest in that. And then also looking at this graph, this is demonstrating the result for clinical attention to weight loss and nutrition. So looking at inpatients, You can see that 3% answered that they wanted less or a lot less focus. And you can see these groups obviously on the left side of the graph. And then 78% said attention was sufficient as is, which is a good number. 20% said that they wanted more, a lot more focus. And then, however, 2 patients did not answer. And then looking at the same graph, looking at outpatients below, 5% answered they wanted less or a lot less focus. 80% said this attention was sufficient as is. And then 15% said they wanted more or a lot more focus. And then specifically for the cachexia patients, 33% said they wanted more or a lot more focus. So you can kind of see that jump in number with people who are experiencing this condition. And then this number is a lot bigger than the inpatients, but 46 patients did not answer. So kind of discussing everything we just talked about. In summary, it is clear that cachexia is a prevalent condition, and the study proves that idea, and this particularly in unselected sample of Norwegian hospital patients with cancer. And it also shows that patients within the study express a need of increased clinical attention to cachexia, especially with the patients that are experiencing this condition compared to ones that are not. And then I also kind of discussed this before, but it was confirmed that cachexia prevalence was strongly associated with cancer type, however, did not find a strong association with the other factors that I listed before, which were treatment type, treatment intent, cancer stage, age, or gender. And then kind of talking about some takeaways that I had reading through this study, I feel like healthcare professionals should be implementing guidelines aimed to detect cachexia and kind of being able to differentiate the malnutrition from the cachexia, because although they are very similar, they are going to have different approaches. With understanding it or seeing it early on, treatment can be more successful. And then by being proactive and understanding how to identify the condition, the distress that these patients experience will be greatly minimized. So it's our duty to our patients to kind of help them in that way. Alrighty, so I did rate this study positive for EAL. However, there were a few things that could have been done differently. To ensure variety, I wish the study would have done more regions regarding inpatient and outpatient treatment. Inpatient and outpatient treatments, I feel like there's definitely some gray areas, even in same regions. And I feel like by doing just Norwegian area, we should have done United States, because I feel like our clinical approaches definitely have their differences. So by doing different regions, we could get more variety. And all in all, hit a home run with the results. And then, so also the study used questionnaire-based data collection. They didn't use any power calculations, which would have been nice, especially when assessing muscle and fat loss. So using those objective measures. And then the article did do a good job of discussing the prevalence of cachexia, because that was the main topic of the study, obviously. But it would have been kind of nice to know in the conclusion just some basic approaches to how to approach the condition and some interventions or a touch on them. Lastly, the study did not really specify how long the study lasted or a follow-up, which would have been nice to know how patients were doing months or years later. Alrighty, so looking at my second research article. The primary objective of this trial, so they assess the safety and tolerability of targeted medical nutrition. And throughout my presentation, I'll referring to this as TMN. And this was while cancer patients received chemotherapy. And then secondary objectives were the evaluation of the efficacy of TMN in improving measures of clinical relevance, including changes in body weight, muscle function, lipid profiles, and compliance with TMN as an add-on nutritional supplement. And then ultimately, this study aimed to improve management of cachexia in patients diagnosed with cancer. So patients in this study, they were receiving first-line standard chemotherapy for non-small cell lung cancer, or NSCLC. They must have been classified as having weight loss grade 0 to 3 and have experienced less than 11% involuntary weight loss in the 12 months before randomization of the study. And then their functional performance status had to be of 2 or less. And then patients who were not allowed to participate in the study, they had second invasive malignancy, brain metastasis, or relapse of NSCLC within the 2 years before the study. So these people were excluded. Overall, this was a 12-week trial. It was randomized, double-blind, parallel group, comparator, controlled trial. And then this study involved 16 sites across 4 countries, which were Croatia, Italy, Slovakia, and Sweden. So patients were randomized in a 1-to-1 ratio. So they either received the TMN or an isocleric comparator group or comparator drink. So they had like the same nutrients for the most part, just to kind of make that comparison. Alrighty, so how they went about this, patients were randomized at baseline to receive either the juice-based TMN drink or the milk-based isochloric comparator drink. They were instructed to drink 2 200 milliliter packages daily of the study product. And then when they presented these white boxes to the patients, they were same shape, labeled A and B. They're, like I said, white boxes. And this was to ensure that the 2 different products weren't identifiable. So they did a good control in that aspect. And patients were also asked not to consume any other products containing omega-3 PUFAs or supplements greater than 150% allowance of vitamin D, just because they didn't want to skew any of their results. And then if the patients participated in any exercise, they self-reported that. So then they were able to eliminate any confounding factors. So looking at the primary outcomes of the study, we're looking at safety and tolerability endpoints, which consisted of adverse events that occurred during the study, as well as changes in vital signs, heart rate, physical examination results, among a few others, but I won't really go into those. And then any secondary outcome endpoints, these included changes in body weight, body composition, and they did this by using the DEXA machine, so it just kind of scans the body and then goes from there. And they looked at fasting plasma levels of triglyceride, hand grip strength, and daily walking distance from baseline to week 12. And then overall survival and chemotherapy-related outcomes, including tumor size, and then response to chemotherapy and chemotherapy tolerability, these were examined as the exploratory endpoints. And then looking at the efficacy analysis, these were first performed on data from all patients who underwent a post-baseline assessment, but these patients didn't necessarily finish the study. They just fell under the exclusion criteria eventually, and then they just didn't finish the 12-week. So these were termed the full analysis set, or FAS. And then looking at the planned analysis, these were performed on data from a group of patients with high compliance. So these are the ones that finished the full 12-week trial. And then, so then these were termed the per protocol set, or the PPS. And then the study did do a follow-up. This was completed at 12 months post-baseline for patients who had not withdrawn from the 12-week trial or treatment period. All right, so looking at the results. So for adverse events, a small number were reported in the TMN group, then in the isocleric comparator group. This came out to be 64 versus 87. And then the adverse events also occurred in fewer patients in the TMN group than the comparator group, which was 18 versus 26. And then looking at vital signs, or particularly heart rate, this decreased in the TMN group, while it increased in the comparator group. However, it did not reach the statistical difference in the FAS, but was significant in the PPS. And then increases in blood pressure were numerically smaller in the TMN group than in the comparator group. And then looking at the physical examination, there were no abnormal results that was not related to the NSCLC during the physical examination. So it wasn't due to the treatment that was being provided. It was just due to their condition or their diagnosis. Looking at secondary efficacy outcomes, patients in the TMN and comparator groups gained body weight to a similar extent over the 12 weeks, making the BMI similarly increase. And then there were no between group differences and changes in the waist and calf circumference, appendicular lean body mass or fat mass, and then changes in muscle area and visceral adipose tissue did not differ significantly between the groups. And then looking at triglycerides, a difference in change was observed in the TMN and comparator groups, but was not significant when considering the PPS, but was only, my apologies, so considering the PPS, it was significant. And then dominant and non-dominant hand strength favor the TMN group numerically compared to the isocaloric drink. And then likewise, the daily walking distance also improved for the TMN group, which is great to see. And continuing with the results, so survival over the 12 months from baseline was numerically higher in the TMN group. A total of 4 patients in TMN group and 10 patients in the comparator group had died by the end of the 12-month follow-up. And then both groups responded similarly to the chemotherapy. And then the same number of patients in the TMN and comparator groups had either a complete or partial response to chemotherapy by the end of the study. And then for tumor size, this was similar for both groups. And then exploratory endpoints concerning tolerability was also similar between the groups. So after discussing that, we can see that this study has successfully demonstrated the safety and tolerability of this targeted nutritional supplement containing specifically omega-3 PUFAs, vitamin D3, and whey protein in pre-cachectic and cachectic patients with this specific lung cancer, and while they were receiving chemotherapy. So it's clear that these demonstrated signs have potential benefits of treating these kinds of patients and warrants further exploration with this approach. And for a dietitian's role, consulting a dietitian plays a crucial role when it comes to this kind of treatment, especially when taking specific measurements for diagnosis and when implicating this sort of nutrition intervention. Alrighty, and then the main limitation of the study that I found was the sample size. It was fairly small, so it would have been nice to see an increase in sample size just to get some more variability and reliability. And then the protein intake of the 2 drinks was a little bit different. So that did have a small potential to skew the results, but like I said, it was a minimal difference, so nothing too significant. Alrighty, and then finally moving on to my third research article. This is a randomized double-blind placebo-controlled clinical trial of megestrol acetate as an appetite stimulant in children with weight loss due to cancer and/or cancer treatment. So the purpose of this study was to determine if relatively large increases in weight could be obtained with megestrol acetate. So I'll be referring to this as MA throughout the discussion. And then I also picked this study just because appetite stimulants have received little attention to being looked at as potential therapies for oncology patients with weight loss. So I thought this was very interesting. And then the end goal of this trial was to improve appetite and implement weight gain in patients with cancer-related anorexia and or cachexia. So subjects included in this study were less than 18-year-olds, so they kind of focused on the pediatric side, and they were diagnosed with a malignant cancer or tumor, and weight loss secondary to cancer and or the treatment. They had lost greater than 5% body weight from their previously reported or recorded highest weight between diagnosis and study entry. Or they had to have a history of anorexia and a percent ideal body weight less than 90% for age and gender. Subjects must have been able to eat orally and were receiving active treatment or palliative therapy with a life expectancy of at least 3 months. And then looking at the patients who were excluded from the criteria or excluded from the study, patients had receiving any enteral or parenteral nutrition were excluded and if they were receiving this at the time of study enrollment, or if they were receiving systemic corticosteroid administration, if they had pre-existing hyperglycemia, pre-existing adrenal insufficiency, they had thromboembolic condition, or if they were pregnant. So this study specifically was a randomized, double-blind, placebo-controlled, investigator-initiated trial, a mouthful there. This trial was performed at the Stollery Children's Hospital and the British Columbia Children's Hospital. Participants were randomly assigned a 1-to-1 ratio, kind of like my other study that I talked about. So it was either the MA group or an equivalent volume of placebo. And then the study proceeded for 90 days. And then they did a baseline and end of study evaluation, which included review of the diagnosis and treatment, weight, height, mid-upper arm circumference, tricep skin fold thickness, body composition, blood glucose, and cortisol levels. And then participants' weight was monitored regularly, and they did it a minimum every 2 weeks. So the primary outcomes of the study was the difference in the mean percent weight change between the MA and the control group or the placebo group. And then the secondary outcomes included differences in the magnitude of change for weight for age, height for age, and BMI for age Z-scores, which I have listed there just because they are kind of hard to remember. And then they also did end of study weight, subjects needing to be withdrawn from the study, and then any changes in body composition or any toxicities that were observed or experienced. So overall, the MA group experienced a mean weight gain of 19.7% compared to a mean weight loss of 1.2% in the placebo group. So this represents a statistically significant difference in mean weight change of 20.9% in favor of the MA group, which is great to see. And then looking at the secondary outcomes, the mean weight for age increased significantly for the MA group compared to the placebo. Although no significant difference was seen in the height for age, but mean BMI increased for the MA group. And then for the mid-upper arm circumference, this also increased significantly for the MA group. And then for the TSF or the tricep skin fold, this did not differ either. And then the end of study weight favored the MA group. So compared to the highest pre-enrollment weight, the end study weight in the MA group was significantly higher compared to the placebo. So kind of continuing with the secondary outcomes. So 4 of the 13 subjects in the MA group required decreases in the prescribed appetite stimulant because of excessive hunger. And then none of the subjects in the placebo group clearly had to decrease their placebo because it wasn't really anything. And then 3 of 10 subjects receiving the placebo compared to 0 of 13 subjects receiving MA, they met early stopping rules for excessive weight loss and were withdrawn from the study before the 90 days were up and had to be put on tube feeds or PN. So all subjects receiving the appetite stimulant increased percent fat mass and changes in their lean body mass, and they were more variable. And then out of 9 MA subjects, 4 lost lean body mass, 2 stayed relatively stable, and 3 had increased. And then similar variability in lean body mass change was observed in the placebo group. Alrighty, so kind of in summary, the study demonstrates that megestrol acetate and potentially other appetite stimulants results in significant increases in weight in pediatric oncology patients with weight loss due to cancer and or cancer treatment. Also, the study did emphasize that improvement in appetite and subsequent weight gain is different than concluding that MA improves nutrition or malnutrition. So overall, the MA was assessed as safe, although the study noted that adrenal suppression was a major potential toxicity. So if this approach does get adopted, that is something to be on the lookout for. And then dietitians also do play an important role when accurately assessing these patients' anthropometrics, like the mid-upper arm circumference, the tricep skin fold, so stuff like that when we kind of look at the NFPE. And ultimately when making the right judgments, how to approach this treatment. Although this MA was assessed as safe and could be potentially beneficial, caution should be taken just because this is a very vulnerable population. All right, to kind of wrap it up a little bit, some changes that I would do through the study. So the study did the mean percent weight change just because it was a lot more, it wasn't as time consuming, although the mid upper arm circumference and tricep skin fold, that could have been considered to kind of measure their outcomes just because although there isn't a consistent approach to nutrition assessment within institutes, I feel like primarily the mid upper arm and then the tricep skin fold ideally could have been a more logical and reliable measuring. And then the study also did not specify or record how much patients were eating within the appetite or with the appetite stimulants, which could have been helpful if further exploring is done. And then they did not discuss the dosage of the appetite stimulant, which would have been nice to know how they determined what patient would get what. I don't know if they did it the same throughout each patient or if they did it determining or based off of the patient's weight, height, age, things like that. And then lastly, the sample size of the study was also rather small. So kind of like how I mentioned in the other studies, higher or more increased sample size allows for more variability. So the 10% in the placebo group, yeah, they had 10 participants, and in the MA group, they had 13. So not very many, but. Alrighty, and then are there any questions for me?